Good afternoon and welcome to the DCRI Research Conference. Also welcome those who are joining us remotely, and just as a reminder that all the DCRI Research Conferences with rare exception are archived so that you can review them at any time and review the slides as well. Pleased to introduce Dr. Andrew Wang, who is with us today. Many of you have had the pleasure of knowing Andrew and working with him previously. He performed his undergraduate work here at Duke as well as medical school, then went to Johns Hopkins for his internal medicine training, came back to Duke for cardiology training, and then returned to Hopkins for a brief period as a chief resident, just like in the good old days, and then returned to Duke to finish up his cardiology training and has been on staff. He's now an associate professor of medicine. And Andrew has a long-standing interest and considerable expertise in the area of valvular heart disease. So I've asked him to speak with this group about platforms for doing clinical research in that particular area. So Andrew, thank you for taking time out to join us today.
Thank you for inviting me.
Pleasure.
Thank you all for coming. Several weeks ago, it was a great honor to hear Eugene Braunwald talk about his, glorious career in cardiology, and he really glossed over this survival curve of aortic stenosis, the natural history of aortic stenosis, which I think is one of the most recognizable survival curves in cardiology, certainly, if not in all of medicine. And from a clinical standpoint, I think that the message which still holds today, 42 years after this was published in 1968, is that death is preceded by symptoms in aortic stenosis. And so a patient can be followed, even with severe aortic stenosis, for many years with a careful history. And when symptoms occur, that sort of is the time to intervene. But if you take a step back and look at this in its totality, I think it tells you a great deal about valvular heart disease in general. So that there is generally a very long latent phase where there is progressive, gradual structural deterioration of a valve, whether it be the aortic valve or another valve, whether it be a stenotic valve or regurgitant valve, followed by the onset of symptoms, and then a later stage where the event rate, the clinical event rate, is much higher. The pace, if you will, may be different depending on the valve lesions, with aortic stenosis being one of the most dramatic declines in survival once symptoms develop. But in general, there's a early, prolonged, slowly progressive latent phase, following by a later phase of disease with symptoms and progressive left ventricular or myocardial dysfunction. And I think we can use this as a template to talk about platforms for clinical research in valvular heart disease. And as you look across the literature, go to the AHA meetings and see what's being done in valvular heart disease, I think that there are three predominant themes or directions of clinical research in valvular heart disease. One is, are there any therapies or interventions that can change the natural history during the prolonged latent phase of disease? And these are generally pharmacologic trials, and for stenotic lesions, focusing on valve morphology, meaning reducing the rate of progression of stenosis. And for regurgitant lesions, particularly the left side, they're focused mostly on left ventricular remodeling. Is there some intervention that can improve or reduce the adverse left ventricular remodeling in patients with regurgitant lesions? There are a great deal of observational studies looking at outcome and prognosis in patients with valvular heart disease, many of which are housed here as registries, ongoing multi-center registries. And finally, a more recent, especially when we talk about transcatheter interventions, focus is on new therapies, improving the outcome in later stage valvular heart disease. And we'll touch on some of these through this talk. If we focus initially on the early latent stage of aortic stenosis as sort of the template, it used to be that we recognized aortic stenosis very late, either due to problems with diagnosis, which is obviously much improved now, but it really became more clinically relevant later in life here. And you can see the time continuum in years demonstrated here. Over the last 10 years, there's been a great deal of attention focused upstream, or the earlier lesions or abnormalities that lead to this later stage of the disease, going all the way back to genetic polymorphisms or mutations that may predispose to aortic stenosis, combined with environmental and clinical risk factors, metabolic signaling pathway, cellular process, and then finally the manifest disease state. And along those lines, there is a great deal of interest in trying to find a modifiable factor here that would change the pace or the likelihood that a patient ends up here with more clinically significant aortic stenosis. As you can see from the previous slide, a lot of these risk factors for environmental risk factors and clinical risk factors developing aortic stenosis look very similar to those risk factors for coronary artery disease. And this is an important paper from Catherine Otto from 1999, where she evaluated the risk for aortic valve sclerosis, which is the predisposing lesion to aortic stenosis, but without any hemodynamic consequence. So it's not impairing left ventricular outflow or necessarily causing increased left ventricular work, but it's the earliest morphologic feature of later stage disease, aortic stenosis. And you can see here the risk factors for developing aortic sclerosis and stenosis are very similar to those risk factors for developing coronary artery disease. This was a population-based study in patients above the age of cardiovascular health study in patients above the age of 65. And the take-home message was not only did it relate to risk factors for coronary artery disease, but patients with aortic sclerosis had a much higher rate of cardiovascular ischemic events in follow-up unrelated to their valve disease. It's a marker of underlying vascular disease. Along those lines, there are animal studies suggesting that elevated levels of LDL cholesterol may be one of the earliest predispositions for developing aortic stenosis. There are many animal models of aortic stenosis, predominantly rabbit models, where increased LDL leads to endothelial injury and fibroblast activation, and that fibroblast activation leads to conversion into osteoblast and activation of osteoblast, leading to many of the sort of bone-like changes or calcification in the aortic valve. And a great deal of interest, therefore, that statin therapy to reduce LDL level may reduce the likelihood or development of aortic stenosis. And with that sort of neat and tidy hypothesis that lowering LDL cholesterol may reduce the rate of progression of aortic stenosis, a number of randomized small clinical trials have been performed over the last 5 to 7 years to evaluate whether cholesterol lowering with statin agents specifically would reduce the likelihood of aortic stenosis progression. And as you can see here, the largest study was the SEAS trial, which evaluated simvastatin plus ezetimibe, 10 milligrams. Many of you are familiar with this because of the signal of increased cancer-related diagnoses in this trial and its impact on the IMPROVE-IT study. As you can see here, most of these patients had fairly normal cholesterol levels, slightly elevated cholesterol levels, and moderate degrees of aortic stenosis with some heterogeneity with regard to other clinical risk factors. And the results of the SEAS trial, published 2 years ago, showed that this combination of simvastatin and ezetimibe resulted in a 50% reduction in LDL cholesterol, shown here, but really no change in the rate of progression of aortic valve stenosis over 3 years. So a negative result for its primary endpoint of aortic stenosis progression. But a significant benefit with regard to cardiovascular ischemic events. It did work just like we thought it would work based on previous studies for cardiovascular ischemic events. And it may be that the earliest injury is due to oxidized LDL, but that the later steps in this pathway toward calcification and aortic stenosis are not amenable to change simply by lowering LDL cholesterol, that there is the additional hemodynamic shear stress involved with progressive aortic stenosis that may play a greater role or perhaps and perhaps a non-modifiable role with regard to the progression to this aortic stenosis. As we move toward talking about treating or evaluating later stage disease, I think that there are a number of potential advantages to studying later stage valvular heart disease. Number one is there's a much higher event rate, as shown here, leading to a need for smaller sample size to show a clinically significant, statistically significant difference in outcome. Secondly, at this stage, many of the testing, evaluation, and therapies are clinically driven. It is not for research-related purposes only, and as a result of that, there is better ascertainment that the diagnosis is correct, as well as quantification of the degree of the disease, as well as a reduced cost to performing a lot of these tests and therapies. And finally, there is a well-defined timing of intervention such that the patient population may be a little bit more homogeneous with regard to their stage of the disease, and you can better qualify or describe their overall condition at the time of intervention, whether that intervention be surgical or percutaneous. And I think one of the best examples of that was just published recently with the Cohort B of the PARTNER study, which evaluated transcatheter aortic valve implantation for aortic stenosis in patients who cannot undergo surgery. If we look at this study a little bit more closely, you can see, again, a relatively small study. A large sample size was not required to show this significant benefit that we'll review here. And it's a very sick patient population here. You can see average age is 83. The operative mortality predicted was over 10% in both groups here. Majority of patients with class 3 or 4 heart failure, high percentage with prior MI, prior cardiac coronary revascularization, significant COPD, elevated creatinine, a very, very sick elderly patient population. Again here, showing the echocardiographic findings, severe aortic stenosis, overall normal left ventricular ejection fraction, slightly reduced, so very sick, a high percentage with frailty here. And in a very short time, it was a 1-year endpoint. Some patients followed out to 2-year. A 20% absolute risk reduction in mortality in this using the percutaneous aortic valve replacement. So really a landmark study, a potential, I think, a game changer with regard to managing later stage aortic stenosis. So what I thought I'd do now is just take you through some of the studies that I've been involved with during my time here. It meshes very well with my clinical interest in structural and valvular heart disease. And in some ways, I think I'm fortunate to have not only clinical colleagues who have helped develop a service and a team focused on structural heart disease, but also collaborated with many of you in this room with regard to some of these studies that I'll talk about here. So we'll first talk about mitral stenosis of balloon mitral valvuloplasty and later stage mitral stenosis, treatment of infective endocarditis with surgery, and finally something I've been involved with more from a site-based standpoint, mitral valve regurgitation and percutaneous mitral valve repair. One of the therapies that is really a first-line therapy for patients with mitral stenosis is balloon mitral valvuloplasty. The majority of mitral stenosis is rheumatic in etiology, and for those patients who have mitral valve anatomy that's favorable, balloon mitral valvuloplasty is very effective and fairly well established as a primary treatment. And we here at Duke, starting in 1990, developed a prospective consecutive cohort of patients treated with this procedure as a referral center for this procedure. And these show the results in 300 patients that were collected over a period of about 8 or 9 years of the procedure. And what we decided to do in this study is evaluate the likelihood of restenosis of the mitral valve after successful balloon mitral valvuloplasty. About 70% of patients have a successful result based on hemodynamic criteria, and these patients were followed over a mean duration of 3.5 years with serial annual echocardiograms to evaluate their rate of restenosis. And as you can see here, there was a gradual, progressive degree of restenosis, such at the end of 5 years, approximately 40% of patients had evidence of restenosis as defined by echocardiography. And the rate of restenosis was statistically associated with the valve morphology at baseline. The more scarred, the more calcified, the more immobile the mitral valve leaflets were at the beginning of the procedure, the more likely they were to experience restenosis. However, when we looked at event-free survival, although there seems to be a trend toward worse longer-term outcome in patients that develop restenosis, when controlled for the acute procedural results of the balloon mitral valvuloplasty, restenosis was not statistically associated with longer-term clinical events. And so, what we learned from this is that there's a high incidence of restenosis after balloon mitral valvuloplasty that was predicted by the echo score or valve morphology, but the clinical events were relatively few. Out of 300 patients, only approximately 10% of patients had a need for repeat valvuloplasty or mitral valve replacement after a successful procedure. Clinical events were more strongly associated with the acute procedural results rather than restenosis, and that may be a theme for other interventions with later stage valvular heart disease. And the limitations to the study, obviously a single center experience with referral and selection bias for the procedure, as well as the observational nature of these data. But that's sort of the weakness of valvular heart disease. In this paper from Pierre Luigi here at DCRI, where he summarized the class of recommendations as well as level of evidence for interventions across the various ACC/AHA guidelines for cardiovascular disease, valvular heart disease is easily one of the weakest levels of evidence for all of cardiovascular disease here. You can see if you focus on level of evidence with level C being the worst, which is simply expert opinion and consensus and case reports, B being largely observational studies, and A being either meta-analyses or randomized clinical trials, 70% of the recommendations for valvular heart disease were class C, or level of evidence C. The next was level B, and 0.3% were based on randomized trials or even meta-analyses. So the level of evidence is much weaker in valvular heart disease, and there is much to be done in this field. I will point out, John, that EP is just right up there with valvular heart disease in terms of its level of evidence. Moving on to the sort of next study I want to take you through is the evaluation of surgery for infective endocarditis. Again, a later stage phenomena where event rates are much higher. These are the generally accepted and ACC/AHA guidelines for indications for infective endocarditis, where there is significant valve destruction leading to hemodynamic compromise or a unlikelihood that the patient can be treated with antibiotic therapy alone for infective endocarditis with a high likelihood of cure. Again, these are generally level of evidence B and C for these recommendations for when to use surgery. There have been a number of studies to evaluate the effect of surgery on mortality in the setting of endocarditis. And this is from a table of a paper that we published recently looking at a number of these studies that used propensity-adjusted analyses for surgery to try to adjust for those differences between those patients who receive surgery versus those that receive medical therapy alone. And this is the present study that we performed here, but a number of other ones, including some from an earlier retrospective data set from the International Collaboration of Endocarditis, which is housed and coordinated here, included in this. And you can see that there were some differences, but the most recent study, which included 61 centers across 28 countries, included the largest group of patients here, and with propensity-adjusted matching, including matching for survival before decision for surgery. It was one of the largest groups here. And there were various different messages that were obtained from these studies, some showing a clear benefit, some showing a benefit for only some subgroups. One patient here suggesting in a single center retrospective, but with propensity-adjusted analysis, that surgery was actually adverse, meaning that patients who had surgery did worse than those after controlling for those factors than medical therapy. Obviously, those patients treated with medical therapy are very different than those that receive surgery. You can see the standard differences here for a number of different variables, baseline demographics for the patients who received early surgery, where statistically these patients look much worse. They're sicker. The only benefit is that they are actually in this group, they're actually young. They were younger, more men, but generally much sicker in terms of their symptoms, their findings, a higher percentage with complicated endocarditis. After propensity adjustment, those standard differences are smaller, and the groups, although still having some differences, are much more similar in the propensity-matched group here. And what we found was that in multiple different ways of parsing the data, in unadjusted analyses, logistic regression analyses, in the propensity-matched, survivor bias-adjusted, as well as using an instrumental variable analysis to try to control for any unrecognized or identified factors related to surgery, there was an absolute risk reduction for surgery across the board for patients with endocarditis. This, again, was limited to a short-term follow-up. It was in-hospital survival. We're actually actively working now and collecting more data on the one-year outcome from this data set. This is a short outcome study showing a clear survival benefit that we think extends to longer-term benefit. And finally, I want to mention, again, a therapy that we've been involved with as a site for studying late-stage disease. And I think it's useful to talk about this, not only to say that there are ongoing randomized trials of new interventions, but also to show some of the complexities, I think, in interpreting some of these results that aren't as clean as the partner study. And this study has not yet been published, but it has been presented at the ACC this past year. So this is a randomized control study of the eValve, now Abbott MitraClip device to repair mitral valve regurgitation. And it is a randomized controlled trial across 30-some centers in the United States and Canada, and enrolled about 280 patients, where it was a 2-to-1 randomization between device and standard surgical repair, as shown here. And the primary endpoint was a safety endpoint, which was a composite of in-hospital outcome of safety endpoints. And the efficacy endpoint was 1 year with regard to moderate or less mitral regurgitation. But it was powered to show superiority with the safety endpoint and non-inferiority on the efficacy endpoint here. It took about 5 years to enroll these patients because of the strict inclusion and exclusion criteria, including the need for quantitative assessment at a core laboratory for the severity of mitral regurgitation. The safety endpoints were major adverse event at 30 days and with a per protocol analysis and a superiority hypothesis. The efficacy endpoint was the clinical success rate, which was freedom from death, mitral valve surgery, reoperation for mitral valve dysfunction, or moderate or more than moderate mitral regurgitation at 12 months with a non-inferiority hypothesis. And with regard to the safety endpoint at 30 days, you can see that it was safer than standard surgery, but this significant difference was largely driven by transfusion, which many people now suggest is not really clinically meaningful if it's driven simply by transfusion alone. With regard to 1 year efficacy, it did meet the pre-specified margin of non-inferiority. Again, the non-inferiority margin was moderate or less mitral regurgitation, which at 1 year may not be reassuring with regard to the need for future interventions if a patient still has moderate mitral regurgitation. In looking at the effectiveness endpoint, there was no difference in the mortality part of the composite endpoint. There was an increase in the need for mitral valve surgery or reoperation in the device group here, and a significantly higher percentage of patients with more than moderate mitral regurgitation, and this is again at 1 year compared to patients treated with surgery. So that the difference in these endpoints here, again, still within the boundaries of non-inferiority, but a twofold higher rate of these efficacy adverse events, if you will, compared to the control group. And looking at it a little bit more closely, looking at the severity of mitral regurgitation, which largely drove the efficacy endpoint here. This is the device group, baseline 12 months, control group, baseline 12 months. Here you can see that the majority of patients here in the surgical group had 1+ or less mitral regurgitation at 1 year, whereas really the highest percentage of patients had at least moderate mitral regurgitation after what was deemed initial successful mitral valve clip procedure. This device now is being, we think is going to FDA panel sometime this year. This device is now in continued access registry, and there is some, I think, concern as to how the FDA will view these data. There were also some issues with regard to the way the data were analyzed on a per protocol as opposed to intention to treat with regard to some of these endpoints. So in summary, when we think about the platforms for clinical research in valvular heart disease, I think that evaluations of interventions for later stage disease are low-hanging fruit given the higher event rate and observational and generally retrospective single center level of evidence. That therapies which target the long latent stage of disease progression have not shown benefit to date, but obviously it's a wide open field with regard to potential targets for therapy. And finally, I think there's a significant gap in the evidence-based management of valvular disease compared to other cardiovascular diseases. Thank you.
Thank you, Andrew. That was excellent. I appreciate your thoughts, and I'm sure the audience has some questions. Matt?
Why do you think we have such a hard time? Why do you think we have such a hard time enrolling patients in studies or trials of valve disease? I mean, the valve disease is fairly common, but do you think the inclusion criteria are so restricted, or that we just have more difficult time finding them? especially the one that took 5 years, I think, to complete, which was
right. All of them have been relatively slow to enroll. I would think that the diagnosis and recognition of early stage valvular heart disease or even later stage is an issue. I think some of the interventional trials have been slowed mostly because of the stricter inclusion criteria, that they are a very well-defined group and there is quantitatively severe regurgitation. The prevalence, especially in an older population, should not be the limiting factor, I wouldn't think.
Yeah, I mean, we've certainly figured out how to enroll patients in trials of coronary disease, whether it's acute or chronic in that setting, or even trials of hypertension or hyperlipidemia for that matter. So it might be that just the way to identify these patients and the type of people who are caring for them can be integrated into structures of screening patients for trials so that future studies could enroll better, because I think that may be one of the reasons why you have such limited evidence. It's just difficult to do the trials.
Right. Right, and it may require, obviously, much longer follow-up in the earlier stage disease.
Yeah, certainly, because it would take a long time to accrue the events you're looking for.
Andrew, if you can just comment, if we talk about percutaneous replacement of the aortic valve, what do you think the major unanswered questions are that could then be used as platforms for clinical trials? I mean, we certainly have the partners' data. What else do we need to know about that particular procedure and that particular subset of patients? Right.
I think that we'll start to see it being studied and utilized, and there's already a randomized study started in Europe in a much lower risk group. And at that point, I think there's a trade-off between a durability of the percutaneous device that's still unknown compared to surgical valve replacement. It's obviously not going to be superior to surgery, we don't think, and in a lower risk subgroup of patients. Partner B is anticipated to be announced either at ACC or maybe TCT again, which is the cohort of patients that had an elevated surgical risk but still were surgical candidates, one-to-one device to surgery. And I doubt, it'd be interesting to see. I doubt it's going to be superior at 1 year outcome, but as we move to lower and lower risk groups, I think the question of durability will be the main issue.
Will it follow the same pathway as coronary bypass grafting versus angioplasty? Is there enough equipoise where you'd say we're going to continue to perform clinical trials in slightly lower and then lower risk groups as the experience with percutaneous replacement increases and the technology gets us to where we want to be?
I can see that happening, particularly as we get more and more data with regard to the durability. Obviously, that's one of the major factors when we think about the type of valve replacement in a patient undergoing surgery. Is this going to be the one procedure then the only procedure that the patient will need over time? I'm trying to think as to some of the studies that other than moving it in a randomized fashion to lower risk groups, what other potential studies would be done. I think that it'll still be limited, obviously, those patients with severe aortic stenosis. I don't think that we're going to see it moving to patients that have earlier stage disease, obviously, because of the upfront risk of the procedure.
Ken.
Hey, Andrew, great talk. It was nice to walk through where the state of the field is right now. I have a comment and a question. First comment is that this is an area where the DCRI has not had a lot of national or international exposure. So it would be wonderful to see how you and others want to leverage the work that's ongoing here on a relatively small scale, and also the work that's going on with Partner right now to come up with a strategic vision of how we could infiltrate this very important disease area as a research group. The question that I have is something that you didn't touch on So I'm going to put you a little bit on the spot here.
Okay, sure.
So the field of anticoagulant therapy is evolving dramatically in a number of disease states, both in surgical patients, AFib patients, acute coronary syndrome patients. What's the current status right now of ongoing evaluations in valve patients for novel anticoagulants? And what do you see kind of evolving in the next 5 years in that field in valve patients?
Yeah, I think it's a very exciting time, and I have heard that there are discussions already with regard to studying some of the novel antithrombin direct 10A inhibitors in patients with mechanical valves. And if to extrapolate from the atrial fibrillation data, I think there's a great promise that these agents will be as effective and safer than warfarin for patients with mechanical valves. And I think that is the next line for, if you look at the patient populations that are most likely to benefit, but in terms of their prevalence, they've hit DVT and PE first, and then they've gone for atrial fibrillation. I think the next step is another indication like valvular heart disease. So I hope that we can, be a part of those studies. I think it's a very exciting time, and may change, some of the risk, profile with regard to thinking about mechanical heart valve therapy. The trend has been over the last 15 years that biologic valves are moving into younger and younger patients, even though we know the durability is only 20 years in the aortic position, 10 to 15 in the mitral valve position, because patients don't want to take warfarin. I think that could change the clinical practice with regard to the way the decision is made with regard to interventions. To make one comment about your comment, I think that there are very few places that can move the field of valvular heart disease out of level C evidence compared to DCRI or places like it. I think that there are very few places that have the infrastructure. There are a lot of registries already here. I think one place as a very small model of it is this international collaboration of endocarditis, which I think is sort of bounced in and out of the picture here, but COLA's here, Tina's here, headed by Ralph Corey and Vivian Chu here. I mean, it really is a very, I would say, unique and really allows for a lot of collaboration that extends the field beyond this single center retrospective approach. It still is observational. It still is a not randomized data. But having said that, it does move things along incrementally.
Yeah, that's what I was going to sort of comment on your last comment there. You made a statement earlier that we know something, like we know that biologic valves wear out after 15, 20 years. I don't think we know that, actually. I would venture to say that if you looked at the literature now, you'd have a hard time knowing that because the literature is so poor. The literature on every part of valvular disease, when you read it, is C-level literature because it's poor. Do we use anticoagulation after you put in a biologic valve? No one knows. Right. What should be the INR ideally set for patients with valvular disease? Is Coumadin ideal for this? It's a hard thing to develop new drugs on top of a system for which there is such limited evidence for what the original drug was used for. I guess the question I would have then coming back to this is, why has this field, which is a big part of cardiovascular disease, struggled so poorly in trying to develop any evidence?
Yeah.
And why have we not moved beyond the stage of my case series of X number of cases under my hands, not even at an institutional level, let alone multi-institutional registries, let alone trials? Yeah,
so I think and I'm welcome to anyone else's thoughts. I think there are a number of things that come, to the top of my head. Number one is the interventions have largely been surgical to date. And I think that, in a way, is somewhat of a hindrance to understanding what happens longer term. They're fixed, they survive the 30-day, and, they go back to their regular doctor. And I think that's part of it, but not all of it. They should be seeing cardiologists. Cardiologists should be aware of these patients. I think there has been less emphasis compared to other forms of cardiovascular disease with regard to funding opportunities available to it. A lot of the work that's done is obviously funded by non-federal funding and granting agencies who I think see valvular heart disease as perhaps a slowly progressive, a very need for long-term follow-up study, and the clinically meaningful endpoints are years down the line, and that you're just going to be focusing on surrogate endpoints like stenosis progression or something like that. But I do think that that it does need to move ahead. I mean, if a trial like PARTNER can be done and show that significant of a benefit in a group of patients who had no other therapy in a randomized controlled setting, it tells you that there are other opportunities like that. It'll take more patients than 300 to show a absolute risk reduction of 20%, but the opportunity is still there.
Andrew, a comment, and then I have a question as well. The one comment is that part of me believes that the guidance documents that come out, and I think we all have been part of those, sometimes facilitate the problem. I'll give you a good example. Anticoagulant therapy with mitral annular calcification or a variety of other valvular disease disorders, where we may make certain recommendations. It may be a class 1 or a class 2A, but people fail to recognize that the level of evidence being C should actually tell us that the evidence is poor, and Eric has made that point very nicely. So perhaps in the context of guidelines, we should be a little bit more forthright to say that just because it's a class 1 or it's a class 2A, don't be fooled when it's a level of evidence C that there is not a need to be doing additional clinical trial work. The question I have for you is, if you can just briefly articulate the trials that are ongoing right now that Duke is a part of in the area of valvular heart disease. What are we doing?
So we're part of the continued access registry for the MitraClip, the realism trial. We anticipate and are working on being a site for the core valve, percutaneous aortic valve trial. And we are continuing to coordinate and collect data and analyze the data from the international collaboration on endocarditis. I think here at DCRI, obviously, that houses the STS. There are a number of ongoing studies. Matt Brennan presented a very nice abstract that Eric was the senior author on at AHA. So in that area, sort of post-surgical intervention. And we are obviously the CEC for the PARTNER trial.
Mm-hmm. Good. So opportunities, no question to work together. So, Andrew, thank you so much for joining us today. It's a superb presentation, and thank you all for your questions and for your attendance.